Today we are going to discuss shortly diabetic nephropathy for the sake of time, and we are going to go through diabetic nephropathy. First, what is diabetic kidney disease? It's defined as albuminuria on at least 2 occasions on testing microalbumin or albumin excretion, and it should be twice. One only it's not enough to label the patient with albuminuria. In presence of hypertension and with or without progressive worsening of kidney function test as reflected by increasing creatinine or reduced glomerular filtration rate. Why it is important to diagnose and treat diabetic kidney disease? Because diabetic kidney disease is responsible for 40% of patients who are developing end-stage renal disease. Diabetic kidney disease is the leading cause of end-stage renal disease worldwide, and there is a strong correlation between cardiovascular disease and increased morbidity and mortality among diabetic patients. At the same time, this kind of patient having overactivation of the glucocorticoid receptors, which is associated with elevated cardiovascular risk and complication reflected on cardiovascular morbidity and mortality, and also leading to progressive fibrosis of the renal parenchyma and development of chronic kidney disease in diabetic patients. And as you see here, diabetes is the leading cause worldwide as the first cause of end-stage renal disease in different countries of the world. And here, as we see, 50%, more than 50% of patients who are having end-stage renal disease are due to diabetes and hypertension. Diabetes is a strong factor for morbidity and mortality, and the prevalence of chronic kidney disease is more than 3 times higher in patients with diabetes compared to non-diabetic patients. And these kind of patients are nearly approaching 4 times the non-diabetic patient. The CKD here is much higher. Moreover, the risk of end-stage renal disease in patients with diabetes is much higher compared to non-diabetic population. As we know that diabetic kidney disease is always associated with higher cardiovascular events, higher rate of renal events with progression of kidney disease, and which is reflected on the patient lifestyle and cognitive functions, increased risk of cardiovascular death, and increased mortality due to all-cause mortality. And as estimated, the patient with diabetes who are having chronic kidney disease are 6 times more likely to be hospitalized compared to non-diabetic patient, and patients with diabetes and end-stage renal disease are 12 times are at higher risk of being hospitalized compared to non-diabetic population. So, here the mortality rate among diabetic patients with albuminuria and reduced glomerular filtration rate is much higher compared to non-diabetic population. And this higher mortality rate compared to patients with normal GFR or impaired GFR only without albuminuria is much higher. So the more the albuminuria, the higher the risk of cardiovascular disease and mortality, and the more worsening of GFR is associated with higher mortality. And combining both albuminuria and impaired GFR increases the risk of mortality significantly. Life expectancy is also reduced significantly with the advanced stages of chronic kidney disease due to diabetic nephropathy, and with the lower GFR, the mortality is significantly reduced. And also at the same time, patients with higher albuminuria, life expectancy is also affected and reduced with the advanced stage of albuminuria among diabetic population. So, as in summary, diabetic kidney disease means presence of high albumin-creatinine ratio more than 2 milligrams, with or without the presence of reduced GFR or increase in serum creatinine. And what happens in diabetes? Glycation of the basement membrane of the glomeruli will result in later protein leakage, and this protein leakage will be later associated with decreased excretion from the kidney and reduced glomerular filtration. with the progression of diabetic disease. As progression of diabetic nephropathy, urinary albumin excretion will increase progressively, and patients who have urine protein excretion above 30 milligram per day urinary albumin excretion will be starting the stage of microalbuminuria, at which the urine dipstick will be negative, and these patients are picked only with urinary albumin creatinine ratio. When the urinary albumin excretion exceeds 300 milligram, will be detected by the urine dipstick to be positive, which is a stage of overt proteinuria with macroalbuminuria, and this is late stage or topic was stage A2 of diabetic nephropathy. And as we just mentioned, it should be not diagnosed as diabetic nephropathy on a single test of urinary albumin excretion or urinary albumin creatinine ratio, but it should be at least 2 readings out of 3 tests with 1 month apart of each. This is why this is to exclude some causes of transient albuminuria, because some patients might present with urinary albumin creatinine ratio above the normal range, and we can't label them as albuminuric patient or diabetic nephropathy because there are some causes that cause transient albuminuria, like patients who are having had recent major exercise or still having urinary tract infection. Patient in febrile illness might have microalbuminuria above the normal range. Decompensated congestive heart failure patient during menstruation, acute severe elevation of blood glucose, acute severe elevation of blood pressure. All these conditions are associated with increased urinary albumin secretion above the normal range. When we are testing the patient for that, should exclude all these causes. Diabetic kidney disease will lead to chronic kidney disease, and chronic kidney disease is classified according to the glomerular filtration rate to 5 stages, from stage 1 to stage 5, or it also can be classified according to urinary albumin excretion from stage 1 to A1 to A3, according to the level of urinary albumin creatinine ratio. What is the goal of management of diabetic kidney disease? First of all, is the prevention. As Dr. Sana before emphasized, that prevention is the main target of our management before developing diabetic kidney disease, and reducing the progression in patients who are already established diabetic nephropathy. We should reduce the progression and preventing the patient from reaching as much as we can reaching end stage kidney disease requiring renal replacement therapy, and at the same time, as also emphasized before, reducing cardiovascular risk and complication in such patients. And the general scheme of management, as discussed before, the glucose reduction and maintaining A1C target around 7, considering some fragile population, special population, and should be individualized according to the patient. Target blood pressure to be less than 130/80 in patient with macroalbuminuria, or less than 40/90 in normal albuminuric patient. The use of ACEs and ARBs is very important for patients who are having especially protein excretion or urinary albumin excretion above 30 milligram, and reducing lipid by using statins or other medication to achieve the target lipid profile to prevent progression of atherosclerotic heart disease or developing cardiovascular complication. A1C lowering is confirmed by different studies that's associated with less incidence of microalbuminuria, different studies showing significant reduction of microalbuminuria, risk of developing or progression of microalbuminuria, and also macroalbuminuria. So A1C is a helping factor for reducing the risk of progression of renal disease. Optimal control of blood pressure, as we just discussed, using ACE inhibitor or ARBs is important for delaying the progression of kidney disease. And as in the renal study, the renal showed that using losartans ARBs is very important in reducing the primary composite endpoint by 16%, end-stage renal disease by 28%, end-stage renal disease, or this due to all-cause down to less than 20% compared to placebo groups. So ARBs showing significant effect for reduction of mortality among patients with type 2 diabetes and nephropathy. But as ARBs is enough to be used and the only way for prevention and treatment in diabetic kidney disease, still there is some limitation for use of RAS inhibition among this population because some people with this diabetic are still having normal blood pressure and they cannot tolerate using of ACE inhibitor or ARBs, and this will limit us from using such medication, which is important for delaying progression. These patients we can't use because they are normotensive or developing symptomatic hypertension while using RAS blockade. At the same time, some population of diabetes and renal disease might have developed significant hyperkalemia that cannot be controlled by diet or other medication for hyperkalemia. These patients will be limited for use of RAS blockade and maximizing the use of or getting benefit of this maximum dose of RAS blockade. So RAS inhibition is always there, but sometimes it is not enough or cannot be used. And there are many studies that try to use other alternative for ACE or ARBs, but the only confirmed of significance and of great value is the ACE inhibitor and the ARBs that shows significant effect as regarding progression, delaying progression of chronic kidney disease. Combining ACE and ARBs didn't show any significant effect on delaying progression of chronic kidney disease. Moreover, it was a very serious variation resulting in severe hyperkalemia and progression of renal disease, even some patients with renal artery stenosis. So this combination failed to show any significance. Direct renal inhibitors also didn't show any significant effect regarding delaying progression of chronic kidney disease. Glucosamine didn't show also significant effect. Anti-inflammatory agents also didn't show any significant effect regarding delaying progression of chronic kidney disease or diabetic nephropathy. And it came that there is other agents that have a significant effect on the reduction of developing diabetic nephropathy and the progression of renal failure, diabetic nephropathy, and the progression to end-stage renal disease as SGLT2 inhibitors. SGLT2 inhibitors showing significant effect for this population recently, and there are many studies that show the beneficial effect for such patients. The action of these SGLT2 inhibitors that it blocks the sodium and glucose reabsorption is approximately pure, increasing the sodium delivery reaching to the macular densa as the juxtafoveal apparatus. And this high sodium content sensed here by macular densa will be reflected, will affect the tone in the afferent arteriole, reducing the size of the afferent arteriole by constriction. This will lead to decreasing the blood burn into the glomerulus, reducing the interglomerular pressure, and decrease the hyperfiltration and delay the progression of glomerulosclerosis by time. And this reduction of the interglomerular pressure is very important for reducing the progression of diabetic nephropathy, and also at the same time decreasing the filtration and the reduction of proteinuria or albumin excretion. So patients with diabetic nephropathy will get benefit of delaying the progression and also reducing albuminuria or even reverting early stages of albuminuria in diabetic nephropathy. One of these SGLT2 inhibitors is dapagliflozin, shows significant effect in reduction of renal composite endpoints and the progression of renal failure. And this was reflected by 24% reduction, relative risk reduction, as regarding renal composite and cardiovascular test. And this was a significant reduction. This is also compared with dapagliflozin, as mentioned by Dr. before, both are showing significant effect on the reduction of progression of renal disease. Moreover, also SGLT2 inhibitors also showed significant effect regarding proteinuria and the reduction of micro to normoalbuminuria is very important, significant, and showed good progression of good regression of early stages of microalbuminuria, or reverting back from macro to normo or microalbuminuria is also significant in patients treated with SGLT2 inhibitors. So in this data, CKD study recently published shows that they included about 4,300 patients in this study. Some of them are diabetic and some are non-diabetic. Diabetics was 62% of patients and 32 are not diabetic. The diabetic patients with type 2 diabetes showed 36% reduction in end-stage renal progression to end-stage renal disease. These are renal endpoint cardiovascular death. Also, non-diabetic patient without diabetes, non-diabetic patients also showed a significant reduction of renal endpoint and cardiovascular death in end-stage renal disease. This significant effect showed in both diabetic and non-diabetic population. If we go to more to sub-analysis, reduction, renal reduction risk, renal risk reduction among renal patients with type 2 diabetes and non-diabetic also was 44% reduction in renal endpoints. It was 29% regarding cardiovascular events and 31% regarding all mortality. So this shows the real value of this group of SGLT2 inhibitors in reverting early stages of diabetic nephropathy and preventing the progression and delaying progression to end-stage renal disease. Recently, the glucocorticoid receptor antagonist, finerenone. Finerenone is a non-steroidal selective antagonist of the glucocorticoid receptors, and it is recently showing promising effects in reducing the progression of chronic kidney disease, especially in diabetic patients, by reducing fibrosis as progressive, causing progressive glomerulosclerosis among diabetic patients, and it shows reduced cardiac and renal hypertrophy, along with lethal reduction in BNP levels and the proteinuria in patients with diabetic nephropathy. The value of this finerenone as a non-steroidal agent is not the same as spironolactone as we are using for the receptor antagonist, that doesn't cause the side effect of severe hyperkalemia that might develop in patients with chronic kidney disease. So finerenone is a safe medicine recently introduced and got FDA approval and probably will be available within this year or next year in Saudi Arabia for use in diabetic patients with diabetic nephropathy. The study of finerenone showed a favorable effect of use of finerenone among diabetic patients with diabetic nephropathy regarding composite outcomes of death from cardiovascular cause, non-fatal MI, non-fatal stroke, kidney composite endpoints, renal failure, developing end-stage renal disease, progression of kidney disease. All patients showed a significant effect and promising effect for using finerenone among diabetic patients with diabetic nephropathy to delay progression of glomerulosclerosis that might happen in diabetic nephropathy. So finerenone is an adjunctive therapy. It is an add-on therapy. It is not a primary therapy for this patient, but it is an add-on therapy, and it shows a promise in preventing the progression of CKD with albuminuria in patients with type 2, for which no current therapies exist for the time being. And in clinical practice, there is lower incidence of hyperkalemia and decreased selectivity compared to current glucocorticoid receptor antagonists, and that should increase the patient compliance via reduction in the adverse events, especially hyperkalemia. Long-term use could theoretically be effective for primary prevention of cardiovascular events and the prevention of chronic kidney disease in patients with albuminuria. A significant reduction of hospitalization suggests that finerenone may have an effect in the treatment of heart failure in the future, but it's not yet confirmed. Finerenone should be added to the formulary with restriction being only used as add-on therapy in addition to use of ACE inhibitor or ARBs as a standard therapy for diabetic kidney disease. Thank you.